Yeah, it's my pleasure again to introduce our presenter, Dr. Per Andren. He is a clinical psychologist and postdoctoral researcher at Lund University in Sweden. His thesis from 2022 is on behavior therapy for Tourette's, specifically for internet-delivered treatment and primarily ERP. He's also one of many authors of the recently updated European clinical treatment guidelines for Tourette's. I hand it over to you, Dr. Andren.
Brilliant. Thank you very much, Julian, for this presentation, and thank you again for inviting me. So, as Julian said, this is the follow-up of last month's presentation, so part 2 of 2. I'm going to give a quick summary of this before we move on to this second part. And I will try to manage the time so we have time for a few questions in the end as well. I think there were really good questions last time, and we had a bit of a discussion, so I think that was fun. So think about all through the presentation if there's anything in particular you want to ask, and I will do my best to reply at the very end. So let's see if I can just move this a little bit like that. And nice. Now let's see. All right, the slides will be available. We know all this. So this is the program for today. We're going to do the ERP part 2 of 2. And then I'm going to talk a little bit about functional analysis and interventions, which is kind of this like basic behavior therapy, but which could be an add-on to an ERP treatment or an HRT CBIT treatment if you're more familiar to that. So it's not really specific to any of these behavioral treatments, but something you can have in the back of your head, or you try to alter various behaviors that are perhaps not really related to any of the specific interventions. I will get to the details, and then I will present a few recent studies on ERP which I've been involved with myself. So you get a little bit of a personal touch, but also an update on a few larger studies that have been published in the last few years here, and then there will be room for questions. So this is a summary now of part 1. We are aware that tics are common and often impairing, that they're usually preceded by these unpleasant premonitor urges. I described a little bit about these phenomena. And then we talked about the treatment guidelines and what they recommend. So psychoeducation should be provided to every patient that is diagnosed. That's the step 1. And then there are several evidence-based treatment options when psychoeducation is not enough for a family or an individual. So it could be ERP, HRT, or medication. And then we primarily talk about ERP. So in ERP, the E in ERP is the exposure. What we're exposed to then is the premonitor urges, and then the RP is the response prevention. So that is suppressing the tics. So it's a little bit backwards. It starts with suppressing the tics, and then you add on the exposure. So now let's start then with part 2 of 2 and dive a little bit deeper into the ERP. And we will start a little bit by getting into detail for each session. So this is a session description more in general. That session should mainly be devoted to practicing ERP with support of the therapist. So, I mean, basically, this session should not be about just following up on homework, giving you homework, etc. You should, how the treatments have been evaluated in studies is that there's been a very, very much of a focus on practicing ERP during the sessions themselves with help of the therapist. So if you're intending on finding the same effects as shown in studies, that's what you should aim for. Here's a few also suggestions for homework assignments. I usually try to give a basic ERP assignment each day, like a steady assignment. Fit into. I think we need to mute someone here now. Let's give me a second. So there's a recurring practice each day for 15 to 30 minutes a day. And you might ask, why is it 15 to 30 minutes? I mean, the better you practice, but it needs to be clear. It needs to be something that the patient individual remembers, and you need to start somewhere. Obviously, we want to generalize this to as many situations as possible, but we need to start somewhere. So we usually start with a clear instruction which can be followed up the next session, and see how it went. So that's the exercise at home, practicing ERP in situations where premonitory urges and tics usually appear. So it's actually like a real practice. And then exercise in other places as well is a good homework assignment. So to every week, choose one or a few situations where a patient can practice ERP, for example, on the bus. So here the idea is just to pick a few situations to start generalizing the practice, but also it might be too difficult to practice in all situations at once, and also the individual might not really remember to do it. So it's a little bit of just so it's easier to follow up and easier to remember for the individual, to pick a few situations where they practice during the week, which is the focus, and then you follow that up during the next session. But obviously, as I mentioned, the goal is gradually to expand the ERP practice to more situations so that suppressing tics becomes more automated and part of the patient's everyday life. But I also want to mention that no one can really force the patients to practice ERP in a given situation. So it's of course up to the patient self if he wants to suppress tics in this particular situation. So keep that in mind. Here I also made a little bit of an even more detailed session by session description. This is based on the manuals I showed last. Especially the Dutch manual in purple, I showed last month, but I also have a slide showing that again towards the end of this presentation. So, anyways, this is kind of mix what I read in the manual with my own experience. So it's a starting point at least. So session 1, providing some psych education, write a list of current tics, give the rationale for ERP, explain how this works, why you're going to do this, and start with the response prevention. And perhaps for children also add a reward chart or something like that, especially for the youngest. And then provide homework, tics diary, and to start with the response prevention for at least 15 minutes daily. And then moving on to session 2, perhaps add a goal formulation if needed. It's usually not as useful as for perhaps an anxiety disorder where individuals are clearly avoiding situations or cannot do certain things. Here with tics, usually they don't avoid things like that, and they can do much anyway. So it's a little bit harder to measure if the goal. We don't want to go just like decrease the tics because it's so hard to measure for and so hard to follow up. But if you find any more like very specific goals that are easy to follow up and measure, then you might do this at this point. And then during the session, do some response prevention with the help of a stopwatch, record the times, have a high score list of the best times, and then perhaps add a little bit about the function analysis and interventions, which I will talk about later in this session. The homework here might be continuing with the response prevention for at least 15 minutes daily. And then session 3, now we're approaching the exposure part here. So here we start talking more about the premonitory urges, defining them, identifying them, estimate their severity, and then adding the exposure to the response prevention. So that might be, for instance, I talked about this the last presentation, but could be focusing on the premonitory urges and where they're felt in the body while doing the response prevention. So now we want to do the full ERP homework for at least 15 minutes daily, with perhaps also the intensity ratings of the premonitory urges. Actually write down this rating from 0 to 10, how intense are the premonitory urges. So you start talking about with the therapist, with the individual about this. Session 4 and onwards are very similar. It's more or less just to keep on doing this ERP. You might use an exposure hierarchy, a ladder. I showed one last time, but I also said, well, it's it's perhaps not super needed. At least you should just vary this practice so it's start generalizing as much as possible. And the same thing, at least 50 minutes daily, and then gradually try to move on to suppressing tics even outside the a priori plan situations and moving on to generalization. So, and then you do this for as many sessions that are needed. I think the manuals they instruct about 8, 10, 12 sessions, depending on the manual you read, but roughly that's something to aim for. But obviously go for as many as the patient might need, and start with them. And then, of course, we are aware that tics wax and wane naturally over time. So it's usually wise to keep an open mind and be able to add some booster sessions or follow up the patients after the end of the treatment, because it could be that when you terminate the treatment, the symptoms are naturally waned a little bit, and you're a little bit fooled. You think it's actually what you're providing in the treatment, but it might be a little bit of a natural course as well. And then you end the treatment, and then after a month or so, the tics are back at the same level, and then it might be very difficult for the individual and the family to get back to the therapist because they might need a new referral or whatever. So keep in mind that this is a patient group where it might be beneficial to actually wait and see a little bit during the follow-up, add a few booster sessions if needed. This might be beneficial for the individual. Now I'm going to show you a little bit of a video demonstration of ERP. It's 8 minutes long. It's in Swedish, so I've subtitled it, and it was also filmed during lockdown. So my colleagues will look a little bit silly with the visors and everything, but we're all used to that now. So to the right is these are just actors or my colleagues acting here. So to the right is a therapist, and to the left is a young patient, Kim, and her mother. I think I'm sharing the sound now as well. Let's see if this works. And you have the link in the presentation as well if you want to see it again. So let me know if this doesn't work. Julian, perhaps you can just shout out and if there's no sound or something.
Välkomna till den här demonstrationen
där
vi ska visa upp hur man kan öva på ERP under sessionen. Och det kommer jag göra tillsammans med Kim, 9 år, och mamma Maria här. Och det här är ganska tidigt i behandlingen. Kim har fått börja öva på att stoppa sina tics lite. Nu ska vi öka svårighetsgraden genom att jag kommer att fråga om Kims varningssignaler också. Och varningssignaler, det är det ordet vi använder för försändningar. Eftersom Kim är 9, då passar det bättre att använda det ordet istället. Yes, så vi sätter igång. Ja, nu Kim. Nu är tanken att du, precis som vi har gjort förut, ska försöka stoppa alla dina tics samtidigt. Och då är det precis som förut, då är det alla tics på en gång.
Ja, men det är jättesvårt.
Det är jättesvårt, men jag vet ju att du har klarat det förut, eller hur?
Ja, men alltså, sen efteråt så var jag alldeles tokig, eller hur mamma?
Ja.
Jag sprang omkring i hela huset och skrek.
Gjorde du? För att det var så jobbigt? Oj, oj, oj. Ja. Det kan vara så. Du vet, när man tränar på att stoppa ticsen, att det tar ganska mycket energi så här i början. Precis som annan träning. Om man ska lyfta en jättetung sån här vikt och så har man inte tränat så mycket. Om man skulle försöka lyfta 50 kilo första gången, då skulle det vara jättetungt. Och då kan man ju bli jättetrött efteråt. Så det kan vara lite samma med ticsträning.
Ja, det var precis så det kändes.
Det var så det kändes, ja. Men det är ju också så med ticsträning, precis som med annan träning, att ju mer man tränar, desto starkare blir man. Och i det här fallet med ticsträning, då är det ju hjärnbromsarna som blir starkare. Kommer du ihåg det? Det är de som hjälper en att stoppa ticsen.
Jag kommer ihåg, jag ska dra åt dem.
Jajamän, du ska dra åt hjärnbromsarna och försöka stoppa alla tics.
Jag lovar.
Och eftersom vi har tränat lite på det här tidigare, och jag vet att du har klarat av det här, så tänker jag att vi ska göra det lite svårare idag också. I början kan man känna sådär, nej jag vill inte. Men jag tror att du kommer klara det också. Och det vi kommer göra, det är att jag kommer fråga om de här varningssignalerna. Kommer du ihåg dem? De här små som känns i kroppen innan
det
kommer.
benen.
För dig sitter det i benen. Hur är det du brukar kännas i benen då?
Det känns liksom som att det kliar i benen.
Det kliar i benen.
Och sen nästan som att det är sån här, vad heter såna?
Som
Vad heter de?
Myrorna?
Ja, precis.
Ja.
Myror som liksom går inuti benen och biter mig.
Precis så brukar faktiskt många barn som jag träffar säga. Att det känns som små myror som killar en. Och så är det för dig också.
Ja.
Mm.
Jag känner det nästan nu bara vi pratar om det.
Precis så brukar det vara när man pratar om dem. Att då känns de lite extra
Ja.
starka.
Mm.
Och då vet jag också att när man gör sådär, när man frågar om varningssignalerna, då kan det bli lite ännu svårare att stoppa ticsen ibland. Och då kan man ju undra, varför gör vi det då? Varför ska vi fråga om varningssignalerna om det
Jag
blir
vet.
svårare? Ja,
Det blir starkare.
exakt. Då blir hjärnbromsarna extra starka
Mm.
när träningen är svår. Eller hur?
Ja.
Så nu ska vi låta hjärnbromsarna träna riktigt hårt idag.
Okej.
Och precis som tidigare så ska vi ta tid och så kommer vi skriva upp rekordtiderna på tavlan.
Mm.
Och sen så när det kommer ett tics, då stoppar vi tiden och då hjälps vi åt allihopa och se när det kommer ett tics. Precis som förut.
Men kan vi vänta tills jag är redo?
Vi kan bestämma tillsammans när vi startar klockan, så kan du få förbereda dig lite.
Ja.
Så att det inte kommer helt pang på. Så. Och då kommer jag under tiden också fråga som sagt om hur det känns i kroppen med varningssignalerna. Och så kommer jag ibland be dig berätta för mig hur jobbig den här varningssignalen känns. Och då kommer vi använda en skala från 0 till 10. Där 0 är att den inte alls är jobbig. Och 10 det är så jobbigt det kan bli.
Då är det liksom myrstackar i benen.
Exakt, då är det myrstackar i båda benen.
Usch, det kommer väl inte bli 10 eller?
Vi får se, det vet vi ju inte innan.
Nej.
Vi testar och provar och så se. Och det här är precis som annat. Vi provar en gång först och sen så ju mer man tränar desto bättre brukar det gå.
Och om det är 10, då tränar du bromsen extra mycket ju.
Ja, det är sant.
Exakt.
Uff.
Jag vet att du klarar.
Uff. Okej.
Okej, ska vi börja med om vi nu... Hur känns det mellan 0 till 10 just nu då i benen, skulle du säga?
Vad är skillnaden mellan 4 och 5?
Det kan ju du bestämma själv egentligen. Det finns ingen sån jättetydlig skillnad.
Nej, det är 4,42.
Ja, 4,42 är det just nu.
Mm.
Då kan vi skriva upp det här också. 4,42 när vi börjar. Känner du dig redo?
Vänta, jag ska räkna till 3.
Räkna till 3. Så kan du få trycka och stoppa.
Får jag sätta?
Då kör vi. Då är vi igång med tickträningen och järnbromsen. Är den på?
Den är på.
Du har satt i den.
Mm.
Jättebra, jättebra. Och då tänkte jag höra lite. Där, vet du vad? Där tror jag att jag såg en tics komma.
Nej!
Ögonblickligen. Men du klarade ändå. Ser du hur mycket det är?
Nästan 20 sekunder.
Nästan
Förra
20
gången klarade jag 35.
Ja. Men den här gången så frågade jag om varningssignalerna innan också, eller hur? Så
Men
nu
jag
har vi
ska
gjort
klara
det lite
35 den här
svårare.
gången
Nu har vi
också.
gjort det lite svårare.
Mm.
Okej. Då skriver vi upp tiden här och så kör vi igen. Så får du sätta igång klockan igen.
Är du redo mamma?
Jag är redo. Jag kollar på dig.
Säg till om du ser ett tics.
Jag lovar.
Jo, den är igång. Nu är klockan igång igen. Och då undrar jag så här. Hur känns det i benen just nu? Kan du berätta lite igen hur det känns?
Det känns inga myrstackar, men
Nej.
det känns att de börjar liksom komma härifrån och på väg mot knäna.
De kryper mot knäna,
Ja.
de små myrorna.
Så kanske typ 3.
En 3 just nu
Mm.
är vi på. Okej. Finns det någon varningssignal som känns någon annanstans i kroppen just nu då?
Det känns att jag vill rycka med axeln.
Du vill rycka med axeln. Hur känns det? Känns det någonting i axeln då?
Alltså det är konstigt, det känns faktiskt lite i benen av det med, men det känns också här.
Ja.
I den här muskeln att den är... Det är nästan som ont på något sätt i den.
Det är nästan ont. Det låter lite jobbigt att det är så.
Får man hålla så här eller är det fusk?
I början så kan man testa sig fram lite vad man tycker fungerar. Men jag tänker att vi ska få prova, se och göra utan. Och där, vet du vad? Nu såg jag en liten näsrynkling som kom där. Så vi stoppar.
Men
Men
över
ser
en
du?
minut.
Det är mitt rekord!
Nytt rekord! Snyggt jobbat Kim! Och det var
Wow.
trots att vi pratade om varningssignalerna. Så
Det var
extra svårt.
jättesvårt.
Jag såg på dig att det var jättesvårt. Det syntes att det var jättesvårt och ändå så kämpade du på och höll i där.
Då måste du berätta det för min lärare sen.
Det ska jag göra.
Superbra jobbat Kim.
Och det var jättesvårt.
Ja, det var jättesvårt och ändå.
Right, we thank Helene, Vera, and Moa for this presentation. Let's see if we can get back to the presentation. So as you saw, this was a demonstration, one way how to do this. There was a lot of focus here on talking about the urge and where it's felt in the body, and like choosing a number for how strong the urge is, rating the urge, and this is kind of how it's described in the treatment manual. So that is from where we picked this up. But this is all a way to try to make it a little bit more difficult, trying to make the urge stronger in a way while still suppressing the tics. So, but this video is available if you want to watch it again or show it for someone else. It's available in this link. So moving on to a few tips here. We want to try to make the practice as varied as possible. So we want to encourage the patient to practice in a variety of situations, both at home and elsewhere, as I talked about. And just like with other exposures, for instance, anxiety, it's important to practice regularly to have an effect, and a patient should preferably practice for at least 50 minutes daily. I've already talked about this. And eventually, the patient can be encouraged to suppress the tics in as many situations as possible during the day. And we want to get the practice into everyday life. So one way could be to make a rule, for instance, that they always suppress the tics at breakfast or in the shower, on the way to work, or the first lesson at school. So this is a way to get into the generalization in a way. So it's just to make it easy to remember and to pick a certain situation during a day where this practice is emphasized. And make the ERP practice more fun. And I will talk a little bit now how this could perhaps be done, especially for younger children. So, for instance, making the practice a game, you could do a fun activity together with the family, play hide and seek, follow the leader, musical chairs, do this, do that. And if so, with tic-like movements, so trying to imitate the tics, but still trying to not do the tics. There's some examples suggested by my colleagues here as well. Tic bingo, draw no, tick-free zones, like when you're in the specific zone in this room, or instance in the house, you should try to suppress your tics. Other tips is just to schedule the practice so that there's less discussion about whether they should practice or not at a certain point. And for younger children, then use a reward chart as I mentioned. And it's good to avoid that parents avoid nagging about practicing. So to make a clear agreement of when and how the parent should remind and when, and then schedule the practice, as I mentioned, might be helpful to avoid conflicts about this treatment and the practice. Could also be possible to ask for help from other people around the family, the teachers, coaches, grandparents to assist on the ERP practice. Here's a second film now. I think I will actually skip showing this, and so we have more time to discuss and have questions. But it's 4 minutes long, and you can watch it whenever you want to through this link, and this is the same format. And in this film, it's a little bit more just like a particular example. They're playing this game, do this, do that, and it's just one of many examples of how you can make the practice more fun. You should not see this as a rule that you need to do this particular assignment, but just an example so how to be a little bit more free in your thinking and a little bit, yeah, trying to just make it as encouraging as possible. Moving on now to a little bit of a troubleshooting here. So I've listed a few usual things that families and the individuals with tics may describe or encounter while doing this practice. So the first here is that a tic is extra hard to suppress. So there's a certain tic that is extra hard to suppress. And what we suggest then is to just focus on that tic until it can be suppressed for 5 minutes or so. So if you remember in the HRT, habit reversal training, the focus was on one tic at a time, but in ERP, we focus on all tics at a time. So what might happen is that it's the same tic that comes and interrupts the practice and the timing each time. And so if that tic is particularly difficult to suppress, then just focus on that tic until the individual is able to suppress it for at least 5 minutes, and then you can move on to suppressing all tics again. And if necessary, perhaps use a competing response as well to try to, from habit reversal training, to try to suppress this particular tic. And I will talk a little bit more about mixing ERP and HRT in a few slides here. There might be also these very small tics that are hard to suppress, especially. It might also be that, especially with young children, they're not really aware that they're blinking with their eyes or doing a nose wrinkle or something like that. So if they're not aware of it at all, it might not be that impairing. So then you might perhaps it might be better to just switch focus to suppressing more of the larger tics, which they are aware of, because we want to find tics that are actually feeling that they're coming, so they can practice to recognize this feeling and then actively suppress the tics. So, and when they practice for some other tics, they might be easier for them to actually recognize the smaller tics, and you can work more with the smaller tics at a later point. And if they're not really suffering from them, it might not be much of a need to focus so much on them either. If the patient does not sense any premonitory urges, and this is quite common in younger children, and it doesn't necessarily have to be a problem. You can perhaps work with the awareness training from the habit reversal training protocol rather, and especially the kind of capture the tic game where the one you sit, the therapist or the parents sit opposite to the young individual. And then the one who discovers the tic first gets a point, or gets to take a candy from the bowl or a match or whatever you're playing with, and eventually the young individual will become better at discovering the tic, because there's also some competition involved in this. And you can also try to ask the individual how it feels in the body at the place where the tic is expressed, and also perhaps start expressing tics and stop halfway. How does it feel? If the premonitory urges or tics do not really decrease following practice, you can try to focus on suppressing tics in the situations the patient primarily prefers, for instance, in school or other social situations. And you can emphasize that they're at least getting increased control over the tics. So they can. Many individuals can describe that their control has increased, even though the overall total tics has perhaps not decreased and that clearly. But in certain situations, they can more decide if they have tics or not, and that might be beneficial and a treatment outcome that is valuable for them. And you can also try to connect the treatment to the specific treatment goals if you decided on any of these. So it doesn't always necessarily have to be about tics decreasing, or especially not about premonitory urges decreasing, because I also told you last presentation, I think, that that's not necessarily always the case. Tics may actually decrease even though premonitory urges are still at the same level. The patient shows no tics during the session, so then obviously you need to try to work a little bit more with exposure, trying to provoke tics, to let the patient purposely do tic movements, look in a mirror, imitate tics, ask about premonitory urges as they did in this video, ask the patient to imagine a situation where she or he has many ticks. Try some physical activity, perhaps, or go to a place where ticks usually appears. If the patient is already used to suppressing ticks, that's kind of usual that the patient expresses, well, I've already tried this, doesn't work for me, or it just works partly. It might potentially be a different outcome when the practice is more structured and when exposure is included, because usually when they practice themselves, I mean, they might be exposing in a way passively, but there's usually not any active exposure, like actively provoking the ticks. And if necessary, perhaps add competing responses as in the HRT treatment. There might also be some confusion among parents regarding when ticks should be noticed and not. So the general advice is that they should avoid to comment about ticks, or that they should not say that the child should stop doing the ticks, but cheering or providing encouragement or providing reminders linked to the treatment, those are obviously okay. I think it could be good as a clinician to provide a little bit of what the expectation, a reasonable expectation from the what effects you might expect from ERP, and I think this also is applicable for HRT. So there's currently no treatment that can completely cure the diagnosis, and with that I mean ensure that the patient's ticks go away completely. So I mean, no behavioral treatment or medical treatment can do that today. I mean, it might be for an individual patient that happens, but not on the group level. So you should inform the patient about what to reasonably expect from the treatment, that they might expect increased control of the ticks, as I mentioned, that the patient can more easily control in which situation she or he has ticks and not. Ticks might be reduced. The premonitoriness might be reduced, and the tick-related impairment might be reduced. And I think the latest point is actually the most common outcome of this treatment, because the treatment also involves other things than just working with tick suppression and adding exposure. It's all about coming, to a therapist, normalizing, getting a diagnosis, getting a lot of valuable information about how it works and the course of the condition, etc. And then working a little bit with ERP and also the functional analysis and interventions I will describe more about. So I think all this added together might usually, even though ticks might not decrease so much, or the premonitoriness might not decrease, the tick-related impairment decreases, which is kind of what in my view, the most important outcome of a psychological treatment anyway. So it might be possible also to combine ERP and HRT. Here's a lot of detail about that. I can say that it's more popular among therapists, especially in Europe, to combine these elements because ERP is more popular in Europe, and so it might be that I think I've already described this more or less, but it might be adding a competing response to suppress a certain tick, and that might be especially if there's the patient is bothered by a large motor tick, which is what, in my view, competing responses are especially efficient in interrupting. So if there's a very obvious large motor tick with the arms, legs, or something where there's a muscle where the patient might easily get voluntary control of this muscle to try to compete with the tick, then it might be a good idea to try to add a competing response for this particular tick. And this has been tried in a study in Denmark. Here's the reference if you're interested. And I think with increased clinical experience in the patient group, you might see benefits in combining various elements of the treatments, because they're quite similar to begin with, but be sure to know what you're doing though, because right here, it's always safer to stick to an evaluated protocol if you don't feel sure about about this. All right. Moving on now to this part about function analysis and interventions. So this is more or less, this is kind of the basic behavioral analysis, ABC analysis, or whatever you might be used from your training. So we want to examine which situations the tics occur the most. So that could be at what times, in what places, during which activities, with which people, when feeling which emotions. So getting a little bit of a background information and trying to analyze when do this individual have a lot of tics. And then working with this kind of like an ABC or SB, I don't know what they're called. We have various names for these in Sweden at least. So it could be that analyzing and finding the situation at home at the dinner table, tired after a long day at school. So the behavior here is a tic. The many motor tics such as facial grimacing, shoulder shrugging, and arm movements. So the short-term consequence of this might be that parents say that the child has to leave the table. So the child escapes and this situation, and tics decrease in the short term, in the moment. And a long-term consequence of this might be that tics are at risk to increase or continue at the next family dinner. And other consequences might be that the child does not eat enough, and there's risk for more tics in the evening because of hunger and fatigue. So this is just an example of what the environment, people around might do when an individual has tics, and how you might analyze this, and how some outcomes might lead to a long-term outcome, which might be more tics, or that tics are at least maintained as such. I think we talked already about the basic rule for family and friends and teachers and such, that if avoidable, we should not openly pay attention to or comment on the tics. Such attention may increase the frequency, intensity of the tics. And family, etc., should not comment, nag, or tell the patient to stop performing the tics. If the patient could, he would of course already have stopped. If the patient himself wants to talk about the tics, then it's of course okay. So family should instead focus on reminding the patient to use strategies from the treatment, but not so frequently that it becomes annoying. So this is kind of this is also a function analysis in a way. So trying to change how parents or other people around the individual behaves, and that might change how much tics comes in a day later during the day or the week. And here are a few examples. For instance, if there's a lesson in school, a lot of tics during a lesson in school, then possibly take a break. Think about the seating in the classroom, inform classmates and teachers about the tics. Does a lot of tics while using screens, then perhaps obviously reduce the screen time, might not be that easy as it sounds though. Do some physical activities prior to screen usage. But also I want to note, it's not always desirable to remove all the fun activities, even though some fun activities might increase tics. So we still want the individual to be able to do fun things, obviously. Homework, if there's a lot of tics during homework, divide the homework, schedule it, do homework when the patient is most alert, have many breaks, sit in a certain place, help with the homework. There's a lot of tics at the dinner table. Try to have an early dinner, perhaps. Instruct siblings not to comment or tease. If there's a lot of tics while getting out of the house in the morning, then perhaps write down the morning routine, prepare clothes and pack the bag the night before. Try to have plenty of time in the morning. Same with the bedtime routine, might be better go to bed earlier, have some calm activities prior to bedtime, listen to calm music, massage, evening walk. As you can see, some of these might be good routines for any individuals, and also if you are having ADHD or autism or such. So we're just trying to bring this thinking into the Tourette's field here, and the tic disorders. Being with friends and the patients gets exhilarated. Well, as I said, we do not necessarily take action in this situation if the patient does not want to, because we don't want to remove all fun stuff. But however, you can encourage the patient to suppress the tics, use ERP while being with friends if patient is bothered at these times. And in general, stress and fatigue tend to increase tics. So trying to reduce stress and fatigue can be beneficial to the patient. There's also some certain situations which I wanted to mention here that for instance, the patient avoids or escapes from tasks during tics. Perhaps so the patients have a lot of tics, and then the parent says, well, you do not really have to do the house chores, or you do not need to do homework, you do not need to attend any activities. And this was also in the example I showed, the purple example a few slides back. So there's kind of a risk here that we're doing the patient a disservice. The patient should not escape things because of tics. However, family can help so that the conditions are as optimal as possible for the patient. So if they need to go away from the dinner table because it's very bothering for other people or for themselves, then they need to come back and eat at a later point, or they need to come back and finish the homework, etc. So there's not any of this. So there's shouldn't be any like secondary wins from having the tics. What does it say here? So yeah, it could be the same with comfort. So relatives comfort and pay a lot of attention to the patient in response to tics, like positive attention. This could be a little bit trouble as well if the individual only get this kind of comfort and positive attention in direct response to tics. So that might actually increase the tics in themselves, because and I'm not saying that the individual is doing this and being aware of this. It's kind of subliminal things that are going on, that when I have a lot of tics, like there's some positive outcomes, etc. And so we want the family instead to focus on providing positive attention regardless of the tics. So that's a good thing to do daily with the children. So do not give a massage only when the child has a lot of tics. Try to do it as a regular activity during that time or so. So that was a little bit of a summary. I will also talk about a few minutes about a few studies here, but a summary about the ERP part 2. So I gave a little bit of a suggested session by session content, and there's more details in these manuals here. I will show in a minute. Session should primarily include ERP practice. Try to vary the ERP practice and make it as fun as possible, especially with children, but perhaps also with adults. And no one wants like a very boring or I'm missing the English word. Let's just skip it. You understand what I'm looking for. Everyone wants it as fun as possible. I gave a little bit of advice in troubleshooting, and combining ERP with HRT could be helpful in some cases, and I gave a few examples on how this could be done, and also that there's a few studies on this. I referenced one of these. And with the help of functional analysis intervention, tics may decrease. So I think the effect you would see from an ERP treatment or an also HRT treatment, if you add the functional analysis intervention, it's probably a mix of various interventions that help the individual in the end. It will be difficult to pinpoint just one thing that you were providing. And then there's the basic rule that families should not comment on the tics. I showed this last presentation. I think they're available. The one to the left is the HRT and CVID manual. I think it's available in North America easily. The one to the left is at least available at the UK Amazon site. So if you want to order one of these, it's available in Europe at Amazon. And this includes the ERP practice as well, HRT and ERP. So just a few words now on a few studies here, which I've been involved with. So we conducted this study a few years back, 2-3 years back, and this was at our specialist clinic in Stockholm, the capital of Sweden, where for children and adolescents with obsessive compulsive disorder and related disorders, and including tic disorders. So this is a naturalistic follow-up, an open study of I think it was around 75 young individuals that had with Tourette syndrome or a chronic tic disorder, which were provided treatment at their clinic naturalistically. So they received treatment. ERP, most of them received ERP, some received HRT, some received a mix of HRT and ERP, and a few also actually in combination with behavior therapy also received medication. So here are the results. I'm not sure if you're familiar with this, called the Yale Global Tic Severity Scale. It's or perhaps I talked about this last presentation actually. It's the primary outcome of more or less all clinical trials of Tourette's and tic disorder. So they started here around 24 points on the scale, which is kind of what you might expect at baseline. And then we had over time we had a quite good increase here, a decrease in tic severity over time here, around 16 points at follow-up directly after the treatment. And then we follow them up 1 year later, and you see that the results were maintained over time. So we kind of concluded here that yes, this treatment that are described in these manuals, the HRT manual and the ERP manual, they can be provided in a naturalistic clinical setting, at least in this kind of specialist clinic as we did, with equivalent results as shown in randomized controlled trials. Now moving on actually to 2 randomized controlled trials. I wanted to show these because these are actually the 2 largest studies of behavior therapy ever conducted in the worldwide, and they are both on ERP treatment, and they are both on treatment delivered over the internet. So remote treatment that has become, which is where the aim is to try to increase availability to this treatment worldwide, but and then to begin with in the UK, which this study is from, and the second study is from Sweden. So here the comparison was an internet delivered treatment of ERP, which was delivered with therapy support in this. So you received a few 10 chapters where you could read information and see videos and write worksheets and see illustrations and such. And then you had text communication with a therapist inside the program. But most of the program you just learned yourself by reading through the chapters and getting all this information. But then the parents and the individual could also send text messages inside the platform to get a little bit of feedback and help with assignments and stuff. And then we had a control intervention, which was not ERP, but was more like a psychoeducational treatment, also in the same internet format. And this is how it looked. So starting from the baseline, they were a little bit more severe in this study than in our naturalistic study. And at the here at the primary endpoint, which was directly after the treatment, this study showed that the active group, the ERP group, was superior to this control intervention, and that was also shown at the follow-up 3 months after the treatment ended here. So quite favorable result, but you can see that it did not drop as far as in the naturalistic study, but this was, I would say, a quite positive result, even though the effect size, the difference between the group was not huge, but kind of similar to what I think we actually expected, because this was a treatment with less therapy support than a regular treatment. So it was, I mean, partly a self-help treatment in a way. And then we also did a similar study in the more or less identical study in Sweden. And then we kind of found similar effect in the active group, but surprisingly, we also find a quite good effect in the control group. So in this particular study, we were not able to replicate the results, the superiority of the active treatment compared to the comparator here. So it was a little bit harder to conclude this study, but overall, I think these 2 studies indicate that, well, there are some indications here that the ERP works in this remote format as well. We will try to move on now, see if this can be implemented in Sweden as a start, and then in the UK, and see if we can follow these up naturalistically and see if this works in the real world as well, and not just only in a randomized study. So if you're interested in these studies, just look them up there. I think they're both open access, or at least the Swedish one is. All right, okay. So we have 10 minutes for questions now, and also to fill in the poll here in the end. So if you have any questions, please write them in the chat. And I think we already have one here. Can you comment on the pro? This is from Elia. Can you comment on the pros and cons of practicing for one 20-minute session versus 2 10-minute sessions? I guess this came a bit early. When is it practice? Is it a homework practice or more like the sessions with a therapist?
Hi
think,
there. Can you hear me?
yeah, thank you.
Yes,
Thank you.
hi. Thanks. Great talk. Nice to see you.
Thank you very much.
This is referring to homework, or like when you say even
I
like, I
understand.
know you say 15 minutes. What about doing 2 15-minute sessions versus 1 30-minute session?
It's a good point. It's a very good question, and I have to say there's really no data on this level. And in ERP in general, there's very little data to describe last month. That there's very few controlled studies, and there's actually just one study that has shown ERP to be superior to a controlled study, and that's the UK trial I just showed you, the internet trial I just showed you. So talking about these kind of details in the manuals, it's more about clinicians guessing and using their clinical expertise. And I would say trying to do it as I would probably prefer 2 shorter sessions and trying to do it as often as possible to it's better because if they come back to the next session, they've only practiced once, it was a really long session. I mean, we really want them to we want to try to get this into their everyday life, generalize this. So I would focus on several shorter sessions if I had to choose. I think that's kind of the reality of many younger children as well, especially if they have comorbid ADHD. The concentration, attention span might be a bit short, and you might need to trick a little bit to get them to do this practice. It might not be as fun as the parents hope it will be. Was that an answer to your question, you think, or?
That's good. Thank you.
Thank you very much. All right. Anyone else has any questions? It could be about last month's presentation as well. Now, summarizing this about ERP, or perhaps also about HRT.
I would add, if you want to unmute.
Yes, please.
Julian.
So sorry. Yeah, if you want to unmute yourselves and pose a question directly to Dr. Andren, please do, if that makes it easier.
Maybe if it's okay, I can ask a second question.
Yes, please.
Thank you. So, it's interesting. I find your use of the term suppress tics.
Yeah.
In North America, we tend to kind of avoid this term for historical reasons. We prefer, we might say maybe control tics or something. It's really more for historical reasons, because when behavioral therapy started to be recognized in HRT early on, there was kind of this defensiveness, because I would be told all my life, my parents, to suppress the tics, and we're telling the parents, don't tell your kids to suppress. We're saying, oh, this is not the same, it's different, it's HRT, we're learning to control tics. This is from the North American context, but I'm curious about your thoughts on this.
That's very interesting. I'm aware that it's more typically. I mean, I think it's described in the ERP manuals, and it perhaps comes from another direction. And I remember from reading and also hearing talks about Douglas Woods and colleagues, which conducted the CBIT studies, that they've been talking about controlling tics, and also they've been mentioning a lot of these myths and what that families have expected, that if you suppress tics, then it would pop up somewhere else and there will become more tics. But I have to admit to say, when with the individuals we met here at our Swedish clinic, I haven't heard much of these, that people have been worried about these myths. They've been very open for, and they've been very eager to try behavior therapy. So I don't know if it's a switch that this information has come out, it's readily available on the internet and they've found it somewhere, or just that it's perhaps this was in a switch where people were more used to medication and was not really as open to behavior therapy. So, but I have never thought about that the word itself. I just thought that they were using different words in North America and Europe. I never thought that could come from the negative association with the word. So that was really interesting. Thank you for that. But I haven't experienced much of this worry from families here. They've been very open and actually been looking for this treatment for quite some time, often. But I mean, we're talking about the same thing, I guess, in the end. So it's more a linguistic thing, I guess.
Yeah. Thank you.
Thank you. Anyone else want to ask something?
Yeah, we have very few questions today, other than Elia's questions. Please do use this opportunity. We have about 5 minutes left if you want to pose a question direct to Dr. Andren.
I don't want to dominate here, but so if anyone else, please unmute and shut me up. But I would like to ask a little bit more. How fast do you ramp it up? How fast do you go up in terms of challenging patients?
I mean, it really depends, but it's not as, I mean, I would say rather fast, and that's kind of what we're doing in our OCD treatments as well. I mean, some treatment manuals, they instruct that the psychoeducation and rationale goes on for several sessions before getting started. I think in the psychoeducation and rationale for these treatments, it's a very simple rationale, and it's also the psychoeducation, what you need to provide to the families can probably be done in like 30 minutes or so. Just describe the course and describe what it's about, normalize, and then get started with the key thing. I don't really see any point waiting, but then it might be individual how difficult it is to actually suppress tics before actively adding the I mean, we want to have a sense of what's kind of their baseline ability before trying to provoking and such. But I mean, it might be rather that you need to do that very quickly because the patient ends up at the session and they have no tics, because that's kind of how it is. And I think many of you recognize that they might have tics in the waiting room, but then they come into the session, and then there's just something there that make in the situations that there might not be actively suppressing the tics. It's just that there's just no tics because of the situations. When you're in front of a new adult, you might not have any tics. It might be. I haven't worked that much with adults, so I'm not sure if that aspect is different, but I would try to move on as quickly as possible, but perhaps not. I mean, one way could be to just try to do various stuff while you're suppressing and go out of the session room, try to see if there's any specific situations that might make the practice more difficult and perhaps also more fun at the same time.
Do you find, Per, that there are certain tics that are, like, if, for example, if a tic has been around longer, that it takes a longer time to get on top of that tic versus a newer tic? We sometimes think
I'm not sure actually, but I think it's more about what they're aware of and the thing I described with how significant they are. And these smaller tics, so like smaller facial movements, blinking, that they're so automatic and they might not be aware of them. So I think it's more about the type of tic rather than how long it has been necessarily around. But I think it's really hard to give this kind of general things because we don't really know much why it's working, what of these various ingredients is the one working, how well is it working. Some evidence is a little bit scarce for especially the ERP, but we know very little about the mechanisms behind HRT working as well. There's a lot of studies showing that it decreases tics, but there's 1, 2, 3, 4 various things that we're doing with we're doing the function analysis, we're doing the HRT, we're doing some relaxation training, we're giving this psychoeducation. It's really hard to know. And then they decrease, they improve somewhat, but not all the way. And then it's like really uncertain what of all the things we did actually work, or was it everything together that worked? So I think all these very specific questions are really hard. I can just guess from obviously from my clinical experience.